Welcome to the latest installment of Reach's Coffee and Conversations. My name is Eric Schnadig. I'm a co-founder of Reach, and it's my good luck to be the host of this Coffee and Conversations. For the occasion, since the topic today is bowel management, I'm wearing my SHIT Happens t-shirt, which Reach makes available on our website and is intended in the positive spirit for all of us HD parents out there. We're joined today by two ideal guest speakers, Casey Trimble and Richard Wood, and each brings a unique and valuable perspective to the topic of bowel management. And I'll introduce them in more detail in a moment. Before introducing the speakers, a couple of housekeeping matters. You may have noticed that we are recording the webinar, and we're planning to share that out after editing all of my silly jokes and comments out of it, no doubt. And for questions, and we hope we have your questions today, please use the chat feature, which you'll see at the bottom of your screen, and you can simply type in your question. It should be set to everyone, and I'll do my best to moderate the questions at appropriate times. So that's the housekeeping. Before introducing Casey and Richard in a little bit more detail, I'd like to give a quick introduction to Reach. For those of you who don't know much about Reach, I'm sharing my screen. Is everyone able to see that? Maybe Casey, give me a thumbs up if you're seeing it. Fantastic. Great. So Reach, education and awareness for children with Hirschsprungs. We're a US 100% volunteer-driven not-for-profit. We also have a Canadian arm with Reach HD Canada, and we collaborate together productively to help families like ours. And I say that because my son Adrian was born 16 years ago with total colonic Hirschsprungs, and that was one of the inspirations for starting Reach. Reach today has really three primary goals. We want to be the go-to resource for families managing kids with HD. We also want to be a bridge between parents and families and the doctors and nurses and researchers that serve them. And then we also, as we can, provide a source of funding to advance the field. And I'll tell you a little bit more about each of these areas quickly here. In terms of resources, oh boy, I skipped all the way to the end there. Sorry, folks. In terms of resources, so what are some of those? So Reach provides connections to the medical community for families. We have how-to videos, FAQs, quarterly newsletters, case studies, and quite a number of other resources. I think a central place to access those is the reachhd.org website. We recently rolled out the HD Passport, which if you're like our family, when you're traveling, and if your child happens to become ill, it's often very helpful if you have something that you can refer to and refer other physicians outside of your normal physician to that explains the condition. The passport is also available on the website. And then most recently, we rolled out a children's book called My Little Brother Has Hirschsprung Disease, which I encourage you to get a copy of if you're interested. We're very excited about that project. In terms of research, Reach has been granting awards to researchers in the field for past 9 years on various topics, from developing diagnostic tools for enterocolitis, and also techniques to advance the genetic research and the physiological research on the causes of HD, all in the effort to find a cure. We hold or had been holding annual symposia for a number of years. We've had to pause that for COVID, but I'm delighted to say that we'll have a symposium coming up this October in conjunction with St. Louis Children's Hospital and Washington University School of Medicine. And that brings together doctors and families in the same room to really talk about HD and make connections and learn about the best way to take care of our kids. I'm going to breeze through some of the previous research grant winners. If you're out there, thank you. Your work is amazing. I'll make a couple of really quick comments on some two recent initiatives that REACH is investing in. We're working on an HD mobile app, which will be a simple tool for parents and families to log information and access information about the health of their children, for sharing with physicians, and for keeping track, frankly, for our own use. I know that we do this today in our family with pen and paper, and it will be great to have a digital equivalent. In addition, we're rolling out or planning to roll out a patient database, which we think REACH is uniquely suited to create. The idea is to create a central database or registry so that as the field advances, researchers can enroll families and children in appropriate studies and eventually, we hope, clinical trials to test new treatments in the field. So that's a brief overview of REACH, some of the things we're doing. We're here to serve you. If you have ideas, suggestions, please reach out to us. All right, so I'm going to stop sharing here. Fantastic. And introduce our wonderful guest speakers today. We have, as I mentioned, Casey Trimble and Richard Wood, both from the illustrious Nationwide Children's Hospital. And Casey, I'm going to try to get all of this right. Bear with me. Currently serves as an advanced practice nurse at the Center for the Colorectal and Pelvic Reconstruction, that's the CCPR, at Nationwide Children's Hospital. She has 15 years of experience as a pediatric nurse in a variety of settings. She completed her master's degree in nursing and advanced practice at Frontier Nursing University. She joined the CCPR team in 2018 and uses her diverse and strong background in pediatrics to care for patients with complex colorectal and urological conditions. Welcome, Casey. How'd I do? All right. And perfect. Fantastic. It's great to see you. Thanks for joining us. And Richard Wood, Dr. Wood is a pediatric surgeon serving as the chief of the Department of Colorectal and Pelvic Reconstruction, at Nationwide Children's Hospital. He's also the associate professor of pediatric surgery at The Ohio State University. He trained in general surgery in the United Kingdom and South Africa. That's why he has such a wonderful accent, and completed his pediatric surgery training at the Red Cross Children's Memorial Hospital in Cape Town. I've always wanted to go to Cape Town. Looks like a wonderful, beautiful place. He subsequently completed a Pediatric Colorectal Fellowship at Nationwide Children's. His areas of interest are complex pelvic reconstructive surgery, including anorectal malformations, cloacal malformations, and, of course, Hirschsprung disease. His research interests focus on clinical colorectal outcome research, and he serves on the executive committee and the arm and Cloacal working groups of the Pediatric Colorectal and Pelvic Learning Consortium, PCPLC. Aren't you glad that I'm introducing Richard and you're not? And the PCPLC is an international consortium of surgeons performing multi-center research in this field. Fantastic. Richard, great to have you. Casey,
thanks, Eric.
Richard, take us away.
Great.
So
Well,
I was going to say, I actually was going to share my screen because I have some slides together for us. If you could just
Casey.
allow that, I think that you had to let me be able to share that.
Yes, I see that. I changed that. Are you now able to share? I think you're on mute, Casey.
Oh, there we go. Yes. Let me pull this up and Dr. Wood can go ahead and start. Can everybody see that okay? Perfect.
Thanks, Casey. That looks great. Well, thank you very much, everybody, for having us this afternoon. Casey and I are very glad to be here, and it's an honor to be involved with your group. I hope you all have your coffee. My accent has a tendency to put people to sleep, so make sure that you're well charged with a double shot. We wanted to go over a little bit of Hirschsprung's physiology, I guess, to try and explain a little bit more perhaps about how children with Hirschsprung's sort of empty differently to patients who don't have, to kids who don't have Hirschsprung's, and then use that as a springboard to talk about bowel management and how we understand it and how our understanding of it's perhaps advanced more recently, and what we think the steps are to manage kids with Hirschsprung's and how this will hopefully keep improving as we go on. So as an overview, and I'm sure most people on the call know this, but just as a place to start, we know that children are born with Hirschsprung's, so it's a congenital condition. An absence of ganglion cells or lack of maturation of ganglion cells in portions of the colon, or sometimes in portions of the small intestine as well. We know this leads to a functional intestinal obstruction. In other words, the peristaltic wave, or the wave pushing the stool through the bowel, is unable to continue on its course through the part of the colon that does not have ganglion cells, and this prevents forward flow of stool. And a lot of people talk about the ganglion cells, but I think a part that often gets neglected is discussing how children with Hirschsprung's do not have a normally relaxing internal sphincter. And so we're going to go through a little bit about how defecation normally works to explain how that internal sphincter plays a role. But that's a really important part of what goes on in Hirschsprung's. It's actually a really important positive part too, and I'll explain that in a little bit too. But it's just a really important part that not everyone talks about very much. So how children present, well, it kind of varies, but a lot of kids will present in North America and Europe will present pretty early in life, the vast majority within the first month. Now, we do see in other parts of the world that kids present much later, and that's because enterocolitis appears to be seen less often, certainly in sub-Saharan Africa, where I used to practice. We saw many kids present much later, but initially we see a lack of passing of meconium in the first 48 hours. We see babies develop obstructive symptoms in the NICU or soon after they go home from being born. We often see this explosive stooling, and the stool may be foul smelling. And this is the sort of initial presentation of a baby developing obstruction and enterocolitis. Now, some kids can present without developing enterocolitis and may just present with significant constipation or the inability to pass gas and stool. And they may also develop failure to thrive because they can have a sort of chronic infective process going on in their gut, which affects the way they are able to absorb the nutrition from their food and this can lead to failure to thrive. I think very importantly, when we see children with Hirschsprungs, while they can be constipated, for us, often what we see more is that they really struggle to pass their gas and they get very distended. And that's sort of a more cardinal sign for us than just constipation. Obviously, constipation is very common. And so often the key trick here is looking at a lot of kids who have constipation and being able to sift out the few that have Hirschsprung disease. And there are some projects up and running at the moment through PCPLC and others that are trying to look at how to risk stratify kids with constipation and work out which ones need biopsies. But in general, those are the ways that these kids can present. So when we want to make a diagnosis of Hirschsprung's disease, there are a couple of things that one can do. Sometimes you'll hear that patients have a contrast study performed. That's when a dye, which is in liquid form, which shows up on x-rays, is passed into the child's rectum and up into the colon. And the radiologists and surgeons look at the pattern that the colon forms, and that can help us see whether we feel that there's a risk of Hirschsprung's disease. Now, contrast studies are not very accurate. They're only about 70% accurate at showing Hirschsprung's on the level. And so they definitely are not diagnostic, but they can be a guide. The next test that can be done is something called anorectal manometry. And that is where the doctor is looking to see if the normal relaxation of the internal sphincter is present or not. And if it is not present, then that could indicate that the child has Hirschsprung. As we just said, that's one of the things that we see in Hirschsprung disease. But the key way to make a diagnosis of Hirschsprung is to take a biopsy. And if we look on the left side here, we see a picture of the colon with its various layers. And what we see in Hirschsprung's is a lack of ganglion cells in both the submucosal plexus and the myenteric plexus, so the whole thickness of the bowel. And we also know that there can be thickened nerves in the submucosa. And so what the pathologists do is they look under the microscope, and that allows them to make the diagnosis of Hirschsprung disease from a biopsy. And then at some point when we do a pull-through operation, we'd use the pathologists to tell us where we'll have found the bowel to be well ganglionated that we can pull it through. So initially, children can be managed in a number of ways. I would say that these approaches have shifted certainly in the last 15 years that I've been doing this. So yeah, 15, 20 years ago, pretty much every patient got an ostomy who got diagnosed with Hirschsprung's disease. And that would either be a colostomy if it was colonic Hirschsprung's disease, or an ileostomy if it was total colonic Hirschsprung's disease. I would say now in a practice like ours in Columbus, we would very seldom do a colostomy anymore on a baby who's born with Hirschsprung disease, who has short segment Hirschsprung disease. So that would be anything from the rectum and the sigmoid colon. We would generally treat children with rectal irrigations and teach moms and dads how to do that. I think it's very important because when you get told that your child has Hirschsprung disease, largely people haven't even heard of it before. It takes them about a week to learn how to spell it. And I think families can feel extremely out of control. And I think one of the huge advantages of teaching moms and dads to do irrigations is it empowers parents, because they can then take over the care of their children again, which is incredibly important for them to feel in control of a situation where they felt very out of control before. And so we have definitely moved away from doing surgery in the first couple of weeks of life, unless we really have to, and have really focused on establishing breastfeeding and establishing irrigations and empowering moms and dads to feel like they're in control of their child's care. with obviously a lot of strong support from the medical team. But having that mindset shift to I can manage this again for parents is huge. And then when they're about 2 or 3 months old, we bring them back and do a pull through, and then the parents are much more confident and much less nervous. And we have generally found that to be advantageous. We recently did a study in the PCPLC looking at children that either had a pull through done as a baby in the first month of life or at about 3 months. And there's no difference in outcome in terms of continence or infection or anything like that. But there does seem to be some advantages in terms of overall parent stress and that kind of thing. So I think there are quite a few of us now who are shifting our practice that way. And then at some point in that care, one does do the definitive operation to pull through the bowel. If they have long segment Hirschsprungs where the ganglion cells only start somewhere in the first part of the colon, or total colonic Hirschsprung's disease where the ganglion cells only start in the small intestine, then one would probably delay the surgery a little bit more. We tend to do our long segment cases around 6 months of age, and the total colonic cases once the stool thickens up, somewhere between 9 months and 15 months, I would say would be average. So when it comes to the surgery, and I understand for moms and dads, all you really want is an operation that works well. But there are sort of 3 general approaches that get used in the United States, I would say. The Swenson approach, which is what we do in Columbus, is where one removes the colon that's abnormal from a level just above the anal canal where all the sensation and muscles are for continence, and bring down ganglionated bowel all the way to the bottom. The next one along, which is the Suave procedure, in that operation, you leave a little bit of the outer wall of the rectum behind to protect the nerves in the pelvis, is the thought behind that. And then the bowel is pulled through that muscle cuff, and that muscle cuff has to be split in order to prevent it causing contraction around the colon. If you think about a napkin ring around a napkin, that's kind of what a Suave cuff can do if it gets scarred down. And that's one of the reasons we sometimes have to remove them afterwards. So it's just something to be aware of. And then for the duomal pouch, in the United States, this is mostly done for kids with total colonic Hirschsprungs, although there are some surgeons who do it for children with colonic Hirschsprungs as well. But there, the rectum is left intact and the pull-through is brought down behind the rectum to form a small pouch. And that's the sort of 3rd most common approach. And as I said, mostly it's done for patients with total colonic in the United States. In the UK, they do it for a lot of patients, but that's not been our practice here in the US.
Okay. So after surgery, I think, we like to say what's next. So surgery happens, and I think a lot of times the expectation is everything's fixed, right? The bad colon is gone. And so now my kid's going to be normal and they're going to poop normal, which does happen, I think, but is not always the case. Because if it wasn't, then we wouldn't be here talking about bowel management for these kids. So before we talk about kind of the Hirschsprungs part, I want to talk about normal defecation and what happens normally to produce a bowel movement, and then kind of the differences between that and a kid with Hirschsprungs. And then we'll talk about what we can do to help the kids with Hirschsprungs overcome some of these differences. So this is a pretty complex process, actually. There are multiple factors that go into having a bowel movement kind of normally. So basically the colon, you have the colon that's moving, or that peristalsis that's moving the stool kind of throughout the entire colon. So that's the colonic motility portion of it. So you need to have normal colonic motility, or that normal peristalsis that moves stool from the beginning of colon all the way through to the end. The rectum then fills with stool. So you feel that stretch in the rectum as it fills up with stool. And then when that happens, you have a relaxation of that internal sphincter, that rear that we say. After you have that relaxation of that sphincter, that's when you kind of sense the need to have a bowel movement. You sense the urge to defecate. Stool then passes into the anal canal, and you can kind of tell the difference between, is this liquid, is this solid, or is this gas? So how quickly do I need to get to the bathroom? Or is it just that I need to pass some gas? You then have relaxation of the pelvic floor and the external anal sphincter. And at the same time, you kind of have contraction of those abdominal muscles as you bear down as you're sitting on the toilet. The rectal pressure is then greater than the anal pressure, and then you pass stool and you have a bowel movement. So there's a lot of things going on at the same time that need to work together in order to be able to sense the need to have a bowel movement, make it to the toilet on time, and then to be able to pass that stool. So what are the differences in kids that have Hirschsprung's disease? So the motility of the colon can be affected. That can be both the colon's moving too fast. So there's hypermotility. Most of the time we see that in patients that have kind of longer segment Hirschsprung's disease. So those total colonic patients, or patients that have had the majority of their colon removed. It can happen in other patients as well, but that's usually when we see that. And then a lot of times we also see kind of hypomotility, or the colon just moves a little bit slower. So you're just not getting that effective push of the stool through the colon. The other thing that we know, as Dr. Wood said earlier, is that that internal sphincter doesn't relax. So you don't have that relaxation of the internal sphincter as it's supposed to let stool kind of through. The dentate line is important for sensation. That really helps us tell the difference between, is this solid stool, is this liquid stool, or is this gas? And sometimes that can be affected in patients with Hirschsprung's, especially during that surgical procedure. So sometimes they can have that dentate line is affected, and they can't necessarily sense the difference between liquid stool and solid stool very well. And then the other thing is the pelvic floor can also be affected as well. You're having surgery to the abdominal muscles, you're having surgery to your bottom. There are a lot of muscles that are involved in having a bowel movement. The core muscles and the hip muscles are very important. And this is something that we are focusing a little bit more on in our center. It's something that we have really within the last couple of years have found that this is super important, and something that we're working on with a lot of our patients now. So this is definitely newer in the last couple of years.
Casey, can I add something if you don't mind?
Yes, of course. Jump in whenever you want.
So just to make the point that that non-relaxation of the internal sphincter is actually incredibly important in order for children with Hirschsprung's to potty train. And we know this because about 15 years ago, some surgeons decided to do colon resections on constipated kids by doing a pull-through. And what they found was that about half the patients had incontinence after that. And so they stopped after a small number of cases. And it made us realize that the only reason children with Hirschsprung's can potty train after a pull-through is because that internal sphincter doesn't relax. And that protects them from having accidents as they get older. So it's a positive thing. It's just something we have to deal with when they're younger in order to help them to learn to push past that internal sphincter that doesn't relax well. And that's a really important thing to think about. It's not a negative, it's actually a positive. It's just, it lands up being a bit of an issue in younger kids because some of them struggle to learn how to push past it. And some of them can develop a bit of a dysfunctional way of learning how to push past it. And that's where pelvic floor physical therapy can really come in and help them to relearn how to push past more effectively. So just to make the point that these are not necessarily negative things. They just, if they don't kind of work it out in the right way, they need to be retaught how to do it in order to be more effective in emptying. And as Casey said, we've been doing a lot more of this in Columbus of late, and we've been finding it to be really helpful. Sorry, Casey, please carry on.
Oh, thank you. Okay, so now that we have all those pieces and we can kind of understand how kids poop and then how kids with Hirschsprungs poop differently, what can we offer for bowel management to help overcome some of these things? So what can we do to help? I first want to talk about kind of the motility part of the colon. So we'll talk about hypomotility first, and what do we have to offer to help kids move stool through the colon more effectively? So the hypomotility is that the stool moves a little bit slower, and sometimes we need that extra push. Here at Nationwide, we typically will choose one of two things to help with that, and that will either be kind of oral medications, or we will do large volume rectal enemas or large volume enemas. There's a lot of nuance into deciding which child does what, and that's a long conversation we have with patients and families, and I won't go into all of that. I'll just go over kind of the things that we use. So when we do oral medications or different medications that we use, we usually choose stimulant laxatives. So there are two different types of stimulant laxatives. Those actually help the bowel contract, and they're going to help push that poop through the colon. Those two medications are X-Lax or Senna, and then there's another one called Bisacodyl. It's also called Cloacal. We like Senna because it's the easiest to get kids to take, I would say. It comes in lots of different forms. So it comes in a tablet and a liquid form, and even a little chewable chocolate square. We find that the stimulant laxatives are actually work a lot better than some of the other medications like a Miralax or a milk of magnesia. Those also are called laxatives, but those are osmotic laxatives. And what those do is usually just make the stool a lot softer instead of helping push that stool through the colon. The other thing that we can do is suppositories, and that's something that I feel like we've really used a lot more in the kids, kind of toddler age children. So we'll usually do a Bisacodyl suppository, and that helps in a couple ways. So one thing it helps with is that internal sphincter. It helps to relax that, like Dr. Wood was saying, they really have to learn to push past that internal sphincter that doesn't want to relax. So the Bisacodyl will force that sphincter to relax for those toddler age kids. And I think he would agree that that's kind of the age that it tends to be the biggest problem. And then it also does give some stimulation of the colon as well, just like taking an oral Bisacodyl. So we found kind of 2-3-year-olds, that's been super helpful in that age group. You're muted, Dr. Wood.
Thank you very much. I always have to do that at least once. So I think it's important, two things. Number one, suppositories are often better tolerated than doing irrigations. And so kids will tolerate that better in our experience, especially in that 2-3 age group. We also get asked a ton about the use of Senna and whether it's safe. And so after us answering this question 1,000 times, we eventually did a study at Nationwide where we looked at like 700 of our own patients and the literature. And I can just reassure families and say that Senna is extremely safe. There's a very small group, about 4% of patients that will get a blistering rash on their bottom, which is probably sort of a contact dermatitis type thing. If they get that, we would swap them over to bisacodyl because it tends to come back. And the only other thing that we were able to find was that you can get basically like a pigmentation in your colon, which is not a precancerous thing. It's called melanosis coli. It really doesn't mean anything. So if you're not embarrassed about freckles in your colon, you're probably okay. And that's really it. And we didn't find any evidence that it's that it becomes addictive or that patients need more and more and more as they get older. So really can reassure moms and dads and say, Senna is extremely safe. We've used it for years on thousands of patients. We've also done a pretty comprehensive study on it and have been very reassured by that. So we get asked that a lot. So I thought I would just. So
the other thing about, I said Senna is available in multiple different formats. The other thing is Senna tends to be a little bit more predictable than the bisacodyl. So if you give it at around the same time every day, with most patients, I would say we're seeing kind of stooling around the same time every day. So as kids are young and they're learning to toilet train, we can use that as almost a way to cheat toilet training. So we'll say, give your medication at 9 a.m. every morning, and then that your kid is going to have a bowel movement around 5-ish p.m. or whatever time that ends up being, and just sit them on the toilet about that time and really encourage them to kind of sit there for a while. Sometimes they do have to sit there, for 15 minutes or so. But we can use that to cheat a little bit. The other thing with the medications is we really dose this based on symptoms and how well it's working. So results, are we having good bowel movements with these? And then are they tolerating the dose that they're on? So we increase it if we need to, and we don't necessarily have a max dose. And then as Dr. Wood said, we see kids need increased doses of medications as they get bigger. But then a lot of times that kind of plateaus out as they reach a certain age. And then I found the longer I've done this is they get into kind of teenage years, they do even a little bit better. And sometimes around that age, we can kind of back off the doses of medications that they need as well. Something about that, later teenage age, I think things click a little bit better. And a lot of times they don't need as high of doses of their medications as maybe they did when they were a little bit younger. So for enemas, this is also a tool that we use for kids who have that slower moving colon. Again, we, have a long discussion, and a lot of this is based on anatomy, previous surgeries, what has worked and what has not worked in the past. But for patients who we do make the decision that enemas are a good route to go, these are large volume enemas that at our center, we use a Foley catheter that has a balloon on the end. We do these either rectally or antegrade, which means that they have something called a Malone or a cecostomy. And then the ingredients that we use are kind of listed over here. The base is saline or water. So usually a large volume, about 400 to 500 milliliters of saline or water. And then we use some of these irritants, glycerin, Castile soap, and liquid bisacodyl, which is a medication we have kids take orally as well. And that kind of helps agitate the colon to help push that stool out. Again, this is based on weight for a first dose, but mostly based on results that we're getting. And the goal when we're doing enemas is that kids kind of do the enema, they have poop come out right afterwards, and then nothing for the rest of the day. So it's very controlled. And so a lot of patients actually like that because they know I'm going to have a bowel movement as soon as I'm finished with my enema, and then I'm not going to have anything for the rest of the day. Dr. Wood, I don't know if you want to just talk about kind of what we found with rectal versus antegrade enemas in kids with Hirschsprungs, because I think, you know, we in the past have done maybe a lot of Malones for these patients, but just if you want to touch on what our research has kind of shown for that.
Yeah, so I think this is when we really started to understand how big a role the pelvic floor plays in kids with Hirschsprungs, was when we started looking at the patients who had had Malones or cecostomies done because they were having incontinence or soiling after Hirschsprung surgery. And what we realized was that there can be two ways in which children with an antegrade enema can really struggle with Hirschsprung. So because you have this non-relaxing internal sphincter, the stool doesn't automatically come out when you do a flush. So they have to learn to relax and let the flush out. And sometimes the kids who've had damage to their anal canal, which we measure by seeing that the dentate line is not present, unfortunately, that can happen during surgery. And if it does, it can affect the way that they can feel and hold stool. But we found specifically those group of patients, because they got so used to holding their stool with their pelvic floor, that actually many of them really struggled with Malones because they just couldn't let the flush out effectively. And so that's a group of patients that we've now spent a lot of time working with them in pelvic floor physical therapy, and many of them are now emptying better with their Malones. And I will say these days, if we have a patient that gets referred with incontinence or soiling after a pull through, and we find that they do have dentate line damage and we can't get them clean with laxatives, and we would want to offer them an enema program, we would try rectal enemas first if they can tolerate those. And then if they wanted to transfer across to an antegrade, and I'm not anti-antegrade enemas because I think they do give kids autonomy because they can do it themselves rather than have mom and dad do it for them. And that's, I think, psychologically really important to get moms and dads out of the bathroom at some point. But we've really found that we have to work pretty hard with their pelvic floor before they do that. And in fact, the timing makes sense because many of the times the kids start pushing towards autonomy at around 6, 7, and 8. And that's the time where many of them would actually be able to do their own Malone flushes. And it's also the time when they can really effectively work with pelvic floor physical therapy. So sometimes it's effective to do rectal enemas until they get a little bit older. And once they're old enough to do their pelvic floor physical therapy and learn how to relax and let the stool out, that's when they perhaps become candidates for an antegrade flush and get that autonomy as they head off into sort of elementary school age. And that's certainly been the way we've tried to do it and have found it to be more effective. I don't know if you want to add anything, Casey.
There was a question that came for both of you from one of
sure.
And it is, if they don't empty well, I'm assuming that means if the antegrade enemas don't empty as well with Malones, do they do better with the rectal? You may have partly answered that, but maybe you could. Yeah, so just to reiterate that. So yes, they do tend to empty better rectally, and then that is a really good indication of when they would often benefit a lot from pelvic floor physical therapy. Sometimes we do Botox a bit as well at the time of the Malone to kind of help relax the internal sphincter just a little bit too. But Botox doesn't do anything for the pelvic floor. So, you know,
we would generally get them assessed now beforehand, and our physical therapists can give us quite a good idea. And often we'll work with them for 3 to 6 months before we do a Malone to kind of work on their core muscles to start with, and then work on relaxation. And then by the time they get the antegrade enema, they're more likely to be successful. So we try and sort of set them up for success by doing work beforehand to help them.
I think the other thing that sometimes we do for those patients as well, that maybe don't empty, is sometimes we will have them do things like do a suppository right after they do their flush. And we found that sometimes just that little bit of stimulation also will help get that stool to come out better. I mean, we, have definitely seen that and struggled through that with patients. And sometimes we have to get creative with what we do and, throw the kitchen sink at them. But I think in the past couple of years, we have definitely found more and more how important that pelvic floor is in all of our patients, but Hirschsprungs especially. The one thing I didn't add on here, but it is something that we also will have patients do, and a lot of times this is for our adult patients that are coming to us for the first time, is we'll have them use the Peristine system. And that's a way to do the large volume enemas kind of more independently. It's a pump system as opposed to a gravity system. And so in theory, patients should be able to, as they're older and if they have good mobility and dexterity, should be able to kind of use that system on their own. Whereas the Foley catheters that we use as kids are younger, it's a syringe with a balloon that needs to be blown up, and it's a little difficult to do that on your own. So in theory, the Peristine you should be able to do for yourself. And I think that really works best in older kind of adult patients, in my kind of opinion, and what I've seen, that usually works best with those adult patients. And that's something that they use, I think, in Europe quite often.
Yeah, so I mean, the point Casey's making is really important one. So a couple of years ago, it's actually more than that now, about 3-4 years ago, we were joined by Dr. Ali Geisha, who works both at OSU and at Nationwide Children's. And so Ali has a practice of looking after adult Hirschsprung's patients and adult anorectal malformation patients, which has been hugely valuable for our patients to know that they have like a medical home all the way through from childhood through to adulthood. And so Ali has a lot of experience working with these adults. Unfortunately, our nurse practitioners do the bowel management with that group, which was one of the things I really wanted to keep, because I feel like we've all learned a heck of a lot about how to manage our pediatric patients from managing the adults, because they can give us so much more information. And so we very deliberately kept the bowel management for those adults at the Children's Hospital, not because of any other reason than that we felt we would learn so much about how to deal with the kids by taking care of the adults. So, and I think the last 3 or 4 years, taking care of those adults is what's really helped us to understand more deeply how to deal with the kids. And we found a lot of success using some of those tricks we've learned. So yeah, big bonus to be able to take care of people. The other thing is really understanding how things change over time. One of the things which has been very interesting is, and we see this both in Hirschsprung's and in anorectal malformation patients, but we have the pre sort of concept in our minds, or I have to say I had it because I'm biased and whatever else, but I always thought the goal was to get all patients onto laxatives. But actually, when we look at the patients we treat and we use an objective tool like a pediatric quality of life score, we actually find that the kids on enemas and the kids on laxatives have exactly the same quality of life when we use an objective score. And the key thing is that the kids are continent. If they're not continent, doesn't matter if they're using laxatives or enemas, their quality of life is down. If they're continent, doesn't matter whether they're using laxatives or enemas, their quality of life is the same. And so we learned that by dealing with older patients. And I think it's changed a lot of our mindset that the goal is a clean child at school in normal underwear who's feeling confident and comfortable. And some of those kids need enemas and some of those kids need laxatives. Their quality of life is good if you're able to achieve those goals. And then the other thing I think that we've learned a ton about is just understanding that kids patients with Hirschsprungs or anorectal malformations need a toolbox, and that we can't be too dogmatic with how we treat them. So we have some patients who, have them alone, and they also take laxatives, and they'll take laxatives during the week, but maybe they'll do a Malone flush on a weekend to clean out, be effective, and not have to worry about where the bathroom might be while they're out for dinner or playing soccer or on a sleepover or whatever it happens to be. And so I think we've become a lot less dogmatic and rather feel like our role is really to give patients tools for their toolbox and then let them sort of work with those tools and work them into their life rather than work their life around their bowel management, because no one really wants their life run by bowel management. It's kind of better the other way around. Okay, sorry, Casey, do you want to go through that?
Yep. So the other part of the motility is the kids whose colons are moving faster, so the hypermodal patients. Like I said earlier, this tends to be kind of those total colonic Hirschsprungs or kids who have that longer segment of diseased bowel. And typically these patients come to us and they're pooping, 10 times a day, which is very, it's not great. It's uncomfortable. And I think the first thing and the most important is for us to set realistic expectations. And we're probably not going to go from 10 poops to 1 poop a day, but we can try and definitely get that number down to give them better quality of life. So the first thing we do is we like to do some diet manipulation, so more constipating foods. And the first medication or supplement we will add is a water-soluble fiber or a pectin. That really helps bulk up the stool. It makes it more formed, so it's not as loose and not as much diarrhea. We then just do Imodium will be our first choice, of loperamide. And we have kind of a max dose that we'll do of that based on age and weight of the patient. And then we'll just kind of go through these different medications one by one until we get the desired effect. So once we max out on the Imodium dose, we'll go to something called Levsin. Cholestyramine is, I will say, it's in this algorithm, but it is definitely difficult to get kids to take it because it's like a charcoaly powder, and I think it's really gross. So I will try it, but I usually don't have much success. So as we're getting into these lower, kind of the lower tiers, we have to start thinking about what are we going to do next? Because I will say I can get kids to take Levsin, but once they're maxed out on that, I have to start thinking about other things because it can be challenging to get patients to take the cholestyramine. And then the Lomotil is pretty easy, but sometimes has some side effects. So, we have to think about other options. Ultimately, some of these patients need an ileostomy just because they're using the bathroom so many times a day and they're completely miserable. They have just constant chronic skin breakdown and they're not continent at all. They're getting bullied at school. And so once we kind of exhaust this list, we will start having that conversation about having an ileostomy recreated for some of these patients. We will do kind of smaller volume enemas, like 100 milliliters of water or saline is what we usually do. Most of the time I'll have kids do that before they go to bed at night, because sometimes we'll get them really good during the day because they're awake and they have better awareness of those pelvic floor muscles. So they're kind of squeezing those pelvic floor muscles all day and they're continent during the day. But as they go to bed, a lot of times that's when we see those accidents, and it's because they're relaxed and they're not squeezing those muscles. So I will have them do, if we're at that point where we're good during the day, at night we're still having some trouble, we're kind of maxed out on a lot of these medications, I'll have them do just a smaller volume enema before they go to bed. Again, not kids' favorite thing to do, but it's another tool that we can use. And if we can get them to sit on the toilet and really empty pretty well before they go to bed, we can sometimes get rid of those nighttime accidents, or maybe they're not as bad.
Casey, can I ask a question? This Tara from the chat asks, how do you feel about Bentyl instead of Levsin?
So that's not one that we typically use. I mean, we will get our GI partners involved sometimes to help us out. That's not a medication that we have traditionally used. That's why down here at this consult, the intestinal support team. So these kids function sometimes like the short gut or short bowel kids. So a lot of times we will refer them to our GI team for help. So I don't have a lot of experience, but we'll pull in our GI motility team and our GI intestinal support team for help with these patients as well. So I don't know, Dr. Wood, if you have anything to add to that.
Yeah, I mean, the only thing I will say is we have also sometimes used the cholestyramine added to a cream or a paste that you can place on the bottom in children with total colonic, because one of the things that really causes rashes in total colonics is the bile salts that are not denatured by the bacteria in the colon, so that can really burn the skin. And if you add the cholestyramine to their bum paste or butt paste, whichever language you speak, English or American, then you can inactivate some of those bile salts, and it can really help with the skin rashes. But yeah, getting patients to take cholestyramine, it can be really hard. I don't think Levsin can relax any of the sphincters. I don't think it has a systemic effect on the sphincters, just to add to the question from the chat.
I have a question coming from the perspective of a kid with total colonic HD. We're sort of trained to beware of enterocolitis sort of above all as the worst possible outcome. And I think as a result, the idea of inhibiting stooling with some of these medicines can be worrisome, or was worrisome for us. How should we be thinking about that trade-off?
Yeah, so when I see these patients, I go really, really slow with any of these medications. This is a very long process. And so I think for me, I'm upfront with patients. You know, we do this week-long bowel management boot camp. And if I have a patient who is hypermodal and needs these medications, I will tell them we are not going to be in a perfect place at the end of this week. This is going to be an ongoing process, but we will continue to hold your hand through this as we adjust things. So we start, like I said, with the fiber, and I'll start with just a very slow dose. I give them a few days to see what happens. And then, you know, after 3 or 4 days, if things are thickening up, then I might increase that a little bit more. When I start the Imodium, 1 tablet is 2 milligrams. Depending on the age of the child, a lot of times I'll just start them on a half of one of those tablets twice a day, and really making sure we're monitoring that and we're not having those symptoms of enterocolitis. So the belly distension, not being able to pass gas, kind of fouler smelling stools. I think the key here is to go really slow. And like I said, we're not going to go from 10 poops down to 1 a day. I think that's just completely unrealistic for patients. And so just monitoring that closely, we're going to go from 10 to 8 maybe to 6 to 5, and that might be where we get, and that might be good. So I don't know if that helps at all, but I think the key for these patients is to go extremely slow with any medications adjustments that we're making.
Yeah, and if I can just reiterate, I think the key to all of this is really straightforward communication. Like, I think one has to be very, very upfront, and I think we have to be very honest with the expectations that we set, and understand that this is a journey, and as long as one's prepared to go on it together and keep communication going, I think one can get there. But just to reiterate what Casey said, you really are balancing that fine line between getting enough stool to come out so that they don't get enterocolitis, but not so much come out that they incontinent and are having rashes and are very uncomfortable and that sort of thing. And so, you've got to walk a tight line, which is much more difficult than, say, the constipated kid with short segment Hirschsprungs is a much less tight line to walk, because you just, you need some stimulant laxatives, and most of them will do extremely well. Maybe some pelvic floor, a bit of Botox, but as you rightly said, Eric, walking that line in total colonic is a lot finer. We know that they are more prone to enterocolitis. We also know they're more prone to diarrhea and rashes and stuff. So it is a tight line. But the other thing I think which makes it harder, and I recently reviewed total colonic for the seminars in pediatric surgery, and the reality is that very few centers see many patients with total colonic. Now, we happen to see a lot of patients with total colonic, so we treat them a lot. But most centers in the US see about 4 or 5 Hirschsprung's patients a year, and 1 in 10 of those kids will be total colonic. So they might see 1 patient every 2nd or 3rd year in a hospital. That's what the data tells us. Whereas a center like ours would see between 5 and 10 total colonic patients a year. So that's just different. And so I think, for things like total colonic and the sort of longer segment patients, there can be some advantages to going to places that treat them a lot, or getting involved with people who see those conditions more, because there definitely is more tricky nuance in managing that tight line that you were alluding to, Eric, than in your standard Hirschsprung's case.
One medication I didn't put on here, and I've probably in my practice started using a lot more in these patients, is Flagyl. And I'm lucky enough to get to interact with Dr. Langer quite frequently, and that's something that I feel like I've learned from him. And it does really help these patients, and we know that it's relatively safe to use long-term as well. And so we will use that as a tool. I use that a lot more, probably, obviously, for enterocolitis symptoms in any of our Hirschsprung's patients, but on a regular basis in these hypermodal kids. And these patients they are definitely some of my most challenging ones to help with the bowel management, just because it's a lot of different medications that we need to use. And a lot of that is getting buy-in from the kids as well, because they don't want to take 30 pills a day or whatever it is. I think that can be really difficult for them. So making sure that they have buy-in and that they are willing to do some of those things, and just checking in with them, especially as they get into preteen, teenage years, and making sure that they're still doing okay with all of this.
Eric, if I might just say one other thing, bowel management is obviously fundamentally really, really important for patients with Hirschsprung's. When we have a family refer themselves or refer to us by a colleague, which also happens a lot, when they're struggling, one of the things that we always do is make sure that there isn't an underlying reason why kids can't empty well with Hirschsprung's. And I think that's a really important thing to think about, because there are some kids who unfortunately will need reoperations to be done. Now, the vast majority don't. And when we looked at our data, we assessed about 650 kids who'd had obstructive symptoms, and we redid about 150 of those. So, only about a third needed something done. But for those third that need something done, we were able to get over 90% of them from irrigations off irrigations. So the point is that you need to be just very mindful of the fact that if a patient cannot empty with laxatives and enemas and whatever, there might be something that needs to be attended to. And I think we generally want to try and do that assessment. As I said, the vast majority of kids, they just need medication and lots of care and hard work with family and their providers, and they can do great. But there's this small group that do need something done. And from my experience, having a comprehensive review, which sometimes involves motility testing of the colon, the anorectum, the pelvic floor and the rectum, and anal muscles, as well as biopsies and that kind of thing, does sometimes need to be done. But the vast majority of kids, it's medication that's required. But just I feel that one just needs to mention that when we talk about bowel management in Hirschsprung's, because there is this group that sometimes doesn't matter what medication you try, they can't empty, and that can sometimes be an indication that there's a problem which needs to be attended to.
Thank you. I don't want to monopolize the questions or the comments, but I also would note in our case that we observed that there's some dynamism in the way the our child's, Adrian, his motility evolved. And we went from quite often irrigating him to less irrigating sort of around the age of 5. And then, there was another shift as he got a little bit older. So in my mind, and I don't know whether there have been studies done on this, but there is a dynamism naturally occurring, I think, in the physiological realm of things. So it's kind of a moving target in some ways. And I think, for parents that are early on in this journey, I just mentioned that so you're aware that even in the more challenging cases, and we definitely were on that spectrum, it does usually get better. And then one more comment I'd make is that for us, and you guys mentioned this, irrigations were, absolutely a godsend. Gave us control, all the things you mentioned. But we had to get over a mental barrier of viewing them as sort of a defeat. And it was amazing how high a barrier that actually was initially. Anyhow, so I mentioned that for the group.
It's great.
Yeah, and Eric, there is actually really strong data to support your observation as a parent. So if we look at big series, enterocolitis is actually very rare over the age of 7, unless there's like an abnormality that needs to be fixed. And I think that is because a lot of kids just become better at overcoming their pelvic floor and their internal sphincter as they become more aware of what's going on in their bodies. And so I like to encourage moms and dads and say, you know, it's the things that cause the most trouble when they're toddlers, which is actually going to allow them to be potty trained and continent when they're older. And so just really seeing all these things as a bridge to get to continence and effective emptying as an adult is really important, because, you know, yes, sometimes one has to do irrigations, and we are very, very encouraging of irrigations because, like I said before, they're empowering, but also they can help to keep you out of the hospital. So if your child gets a viral illness, and we know that viral illnesses can affect motility when kids are sick, that can be enough to sort of tip them into enterocolitis if they're sensitive. And if you just are in tune with that and you see your child gets a viral illness and you preemptively do some irrigations for a couple of days, that can prevent an enterocolitis episode and an admission to the hospital and all the things that go with it. So completely agree it's a mental barrier, but I think it's up to those of us that treat families and kids with Hirschsprungs to really try and normalize that as much as possible. And that's why I've been such a proponent of delaying the pull-through, so that it becomes normal that you're doing irrigations. It's not a defeat, it's just that's what you're doing. And then once you have families in a position where they realize they're in control and this is normal, then we are able to hopefully have less of a defeatist mindset around the irrigations. And, you know, we have a psychologist in our clinic. We work with psychology a lot because I think, you know, it's helpful, because I think these are difficult things for moms and dads, they're difficult things for families. And so we have to try and provide support, not just physical support and medication support, but also emotional and psychological support too. And to the kids as they get older too. So there was a question in the chat there about puberty. Yeah, you know, I think, you know, there are various stages in kids' lives when they go through a change. Puberty and growth spurts can be one, sort of that later elementary going into middle school age can be another challenging time when they decide they don't want to do anything anymore. So we would often encourage families, we can make a few tweaks here and there, but if we're struggling, we need to reboot, we might do like a boot camp, like Casey said, just a week to kind of reset things and just make sure we're not drifting in the wrong direction. I think there have been very few positives to COVID, but one positive we did find was we learned how to do bowel management with telemedicine. We were never proponents of that before, but we actually found it to be as effective. We often will do sort of hybrid where you'll come for an initial visit, get everything started, do an exam, make sure there's nothing mechanical we need to fix. And then, you know, you'll go home and do the rest of the week from home using, you know, Zoom calls and stuff like that. And so we've found that to be very effective. So for established patients to do sort of an intensive week from home with Zoom and a couple of x-rays here and there has been a really good way to reset. So I would say, you know, work with your providers. If you're finding you need a reset, might be a few tweaks, but if it's more than that, then sometimes doing a reset with a week of bowel management to get back on the horse is often very effective.
I just want to add to Dr. Wood, you mentioned psychology, and I think that for any kid with a chronic medical condition, I think it's important to get them involved because they're going to be able to help with some of those transition periods. So, you know, how in someone who has experience working with kids with chronic medical conditions, it doesn't have to be Hirschsprung's, but someone who can talk about some of these difficult things, because the reality is, you know, preteens and teenagers just want to be like their peers and they don't want to take medications. And some kids are really great about that and they have that understanding at an early age, but a lot of patients stop taking their medications, or I'll see them back and they say like, oh yeah, I stopped doing that a year ago. And the parents have no idea even. And so I think being able to talk about that stuff from an early age with psychology support, and then, you know, you have that support as they go through some of these difficult transitions, can be really beneficial. And so I would just encourage people to kind of seek that out maybe early on, so you have that kind of established as kids get older.
Right. And then there's a question here about colonic and anorectal manometry before an ACE. You know, I would say we kind of very much try and individualize care rather than protocolize. There definitely are some patients where we would do colonic and anorectal manometry prior to doing an ACE. I would say we wouldn't do an ACE without an assessment by a pelvic floor physical therapist. I think that's an absolute, we wouldn't go ahead unless we had an assessment done. I don't know that everyone needs motility testing. I think there are some kids where they can have a pelvic floor physical therapist see them, say, look, everything looks like it's working well. We should be good. We've worked with them a bit. We know their colon's working nicely. And it's just a change of route more than anything else. And then there'll be other kids where we're really struggling, and then getting more information can be extremely helpful. There's a very small number of patients where the colonic manometry is a key problem, and we've actually had to redo pull-throughs on patients where, although they had normal ganglion cells, the colon did not function for like 15, 20, 30 centimeters. And so sometimes we had to actually just remove that. So there is a spectrum. And I think based on our assessments and management and seeing how kids do, one works out how much of that testing one needs to do. I'm also mindful of the fact that the testing is expensive. And so we don't want to kind of do it for everybody, because that can just be wasting some people's money. And so we really try and work out which patients would benefit the most from it, and then use it on those kids to try and inform what they might need.
We really like to do rectal enemas on kids first before we offer them that ACE or that antegrade option. And I mean, some kids won't tolerate the rectal, so we really try to individualize care and take into consideration everybody's needs. But we have found that if you can empty well on rectal enemas, for the most part, except for those patients that have pelvic floor issues, that really translates pretty well to that antegrade, or doing that flush through them alone. And the solution tends to stay about the same. So the regimen, the ingredients that you use are usually pretty much the same. Okay. Okay, so here's just some examples of the fibers that we use. We'll use the powdered mostly, so the Citrusel or the Metamucil. These are the name brands. The generics work just as well. The Nutrisource fiber, I think, tends to be a popular one just because kids take that pretty easily. We've had variable results with it. It works for some patients, it doesn't. We started using occasionally some like brand cereals, and then the pectin also, it's not a fiber, but it does kind of work the same, where it adds that bulk, or it's more of like a jelly consistency to the stool. There's a brand that's better than the Shore Gel that tends to be disgusting. So there is one that is kind of a better brand, but that's just the picture that I put up. We don't use it a lot, but I know Dr. Langer uses kind of bran flakes as well, and kind of mixing that in yogurt, oatmeal, and things like that. But here's just an example of some of the fibers that we will use. And we do use fibers in the hypo modal. So the kids who are on laxatives, sometimes they need the fiber too, because the doses of laxatives that they need to get the stool out are high enough that they cause some loose stools, which can cause some issues with like leaking and smearing. And so we kind of counteract that with some of these fibers as well. So both of our patients, both kind of those arms of hypo and hypermotility will sometimes need the fibers. But again, that's all kind of individualized as well. Dr. Wood, you kind of went over this, but, you know, for that internal sphincter, you know, how do we kind of overcome that? And we will use Botox the majority of the time. That's in younger patients because they really struggle as they're infants up to 2, 3. Usually by the time they're getting kind of to that age where they don't get as much enterocolitis, 4 or 5-ish age, they don't need it as much. So Dr. Wood, you can correct me with this, but usually that's kind of when we're doing the Botox, is kind of in that infancy to really help kids be able to stool past that tight internal sphincter. We don't see necessarily that that's a long-term thing because kids kind of figure that out. They can have trouble around that toddler age just because that's when they become more aware of the ability to control their external sphincters as well. So they have more stool holding. And so sometimes that kind of translates into holding on gas as well. And so we will use that kind of around that age. We don't use it as much. We use it for the stool and the gas, but we really worry more about kind of kids who have that gas trapping on their x-rays, who parents tell us, you know, they really aren't passing gas. They never hear them fart. They're having belly distension. And so a lot of times that's kind of when we decide to use the Botox versus, hey, we just need to maybe increase their Senna dose to help get that stool kind of moving along. Do you agree with that, Dr. Wood?
Yeah, I would say I think that Botox is very helpful, but I think it's not a universal magic bullet. And I think perhaps sometimes it almost gets overused. I think if you have an internal sphincter problem, then Botox can help, but I don't think it's an effective treatment of constipation. And I think sometimes it gets used to treat constipation, and I think kids do better with constipation treatment. I'm also probably slightly biased because I worked in South Africa for many years when we didn't have Botox and we managed to manage our Hirschsprung patients just fine. So I do think it has a role, but I don't probably use it quite as much as some people do. I also think that, you know, you've got to be treating a particular thing rather than just giving it to someone who's not doing well. The other thing is we always use a wonderful trick to help gas out of kids with Hirschsprungs, which is to lie on their belly with a small roll under their hips. And if you put them in that position, they will generally pass gas really well. And so any child that's old enough to lie on their tummy, and you know, we have a substance more addictive than heroin called an iPad, and that can help kids lie in a position which is really helpful. So I encourage my families to put their kids on their tummies a couple of times a day once they're old enough for 10 or 15 minutes with a small roll under their hips. And that often will help them to pass gas really effectively and keep them from having to do Botox until they get a little bit older and they just get better at doing it. So I think there are lots of bridges that we can use. Botox is certainly one, but it's not the only one. And I think, you know, it needs to be used in a mindful and thoughtful way rather than just, you know, chuck it at the problem and hope for the best.
And so for our older patients, this kind of segues into the pelvic floor stuff. So as they get older, we really work on the pelvic floor. So pelvic floor physical therapy is a tool that we have started using, and it's been really amazing. You know, they'll work with them for strengthening of those pelvic floor muscles, strengthening of those core and hip, all of those kind of muscles that interact with the pelvic floor. Toileting position tends to be really important. So, you know, you want your kids' feet elevated actually. So knees need to be elevated. I know it sounds silly, but squatty potties actually are really great for kids with Hirschsprungs and kids who have kind of constipation. Knees kind of out a little bit, so legs kind of spread, relaxed breathing. Sometimes blowing bubbles and things like that will help kids kind of relax and help be able to push stool out. a little bit better. And so the pelvic floor therapists obviously can do more in-depth work, but those are some things that kind of we as clinicians in our clinic can talk about. I don't have that training. And so just for people who don't know about pelvic floor physical therapy, so these are physical therapists who then have an extra year of training specifically in the pelvic floor. So they go through like a fellowship, like Dr. Wood did when he did his surgical training. And it is an actual program that they go through to get this extra certification. For kids, mostly they don't do any internal work, so they're not doing like internal exams. I try and reassure families, especially with the little kids. I think they get worried. They will do that for the older kids, teenagers who are able to consent to that. And then the other thing is, it is really challenging to find a pelvic floor physical therapist that will work with pediatric patients. We are very fortunate enough to have several at our hospital, but a lot of our patients come from other areas, and some of them are in rural areas. So pelvic floor PT, most of these physical therapists are treating women. So postpartum issues, the majority of them are treating women. So to find someone who's had that training and then is also willing to take on pediatric patients can be really difficult. Kids need to be about 4 to do this. We'll have them set up with an evaluation, because just like any physical therapy, I think if I injure my knee and I need to kind of do some rehabilitation of that, you're having to do exercises at home. And so you really have to be kind of consistent with that routine that they're giving you. So kids need to be able to follow commands and then have an understanding of what they're telling them to do. So it can be a great tool. And it's something that we have started referring almost all of our Hirschsprung's patients for, if we can find a physical therapist in their area. And we think that it's beneficial. We'll see that coming down the pipeline, I guess, when we get more patients doing this. But I have had success with several patients who have really struggled. And then after several months of this physical therapy, they have done so much better. It is not a quick and easy process. So it's usually several weeks, just like any other physical therapy would be, to months to, I recently had one of the pelvic floor PTs was shadowing me the last couple of weeks in our clinic. She said that they'll actually see their patients back sometimes kind of on an annual basis just to check in. So it can be a lengthy process, but we have found that it is really beneficial. And then I just wanted to share, so we have talked at length about irrigations, but I think kind of you can't talk about that enough with the Hirschsprung's kids. And just to remember that that's kind of always a tool that you should keep in your back pocket, even as your kids get older. You should always, I said to a mom yesterday, like anytime I hear a kid with Hirschsprung's kind of looks funny, the first thing I'm going to say is like, go ahead and do an irrigation, and then let me know how things go. So it doesn't matter how old the kid. Usually, like Dr. Wood said, that kind of enterocolitis doesn't tend to be a problem as they get a little bit older. So past that 6-7 age, we're not doing as many irrigations. But I think for families, it's something that you should expect to do as your child is throughout really their lifespan, mostly in those younger years. So just kind of expect that, and that should be something that you have the supplies to do, and you're able to do that kind of at a moment's notice. So here's, I just wanted to share this action plan that we have put together. A lot of times kids with asthma kind of have this green light, yellow light, red light action plan. So you can see when they have certain symptoms, that's when you need to step up their medications and their inhalers and things. And so we've kind of taken that from that asthma group and decided to put something together for our Hirschsprung's kids. So all of our patients in clinic are getting this as they're getting discharged from the floor. Kind of every time we're talking to them, we're kind of reminding them of this action plan. So obviously you want to be in this green zone, and you're always looking for symptoms of that next zone. And it's really just kind of step by step what to do. green means go, you're doing well. Yellow, maybe that's kind of when we start doing those irrigations. And then red is usually we probably need to go to the hospital. So that's just something that we have put together. You kind of shared some of your resources with us. So it's just one of our resources that we have come up with really in the last, I think that we came out with this a few months ago. So
that's fantastic, Casey. I think, as I expected, there was a request to share that with the attendees. Maybe you can think about the best way to do that. Maybe your website, or if you'd like Reach to be involved, let us know. I just want to, we're right at the little past our 90-minute mark here, but I want to give a virtual round of applause to our amazing, outstanding speakers here today, Casey and Dr. Wood. Bravo. I learned a lot. I found it incredibly helpful, and I'm sure I speak for all of the attendees when I say that. I want to thank the attendees. Fantastic attendance, great questions. And I want to wish all of you guys a safe and happy Memorial Day if you're in the United States. And if you're not, happy Friday anyway. Okay, I think that's a wrap. Thanks so much.
Great, thank you, Eric. It was a pleasure to be here, and we'll communicate and get the action plan to you guys. We have it in English and Spanish, so I'm sure we can share that.
Yeah, thank you so much for inviting us to do this session. Dr. Wood and I could talk forever about these topics, so we can be a little long-winded. Thank you for bearing with us, and maybe we can do this again someday.
Let's do it. I'm thinking about nutrition. It's right on the tip of the tongue after all of this bowel management. Thanks so
we
much.
have 2 nurse practitioners who were dietitians in a past life, so I'm sure they would be all over that.
Let's make it happen with pleasure. Thanks so much. You guys were fantastic.
All right. Thanks, Eric. Chat to you soon. Keep well. Thanks, guys.